Welcome back. We're talking about advancing integrated care model in the academic settings. On the screen with us is Dr. Maryellen Westerberg and Dr. Randy Stinnett from Loma Linda University. A warm welcome to you both.
Thank you.
Yes,
Thank
thank
you.
you
Glad
for
to be
having
here.
us.
Yeah, thank you for being here. Can you please tell us your roles in behavioral health?
Well, currently I'm the Executive Director of Behavioral Health for the SACHS Health System, which has had a long-standing history as being affiliated with Loma Linda University Medical Center. And so that is my primary role with the clinic. And then Dr. Stinnett is one of our therapists, one of our psychology providers.
So, integrated care model has gained a lot of traction this past few years. Centers for Medicare and Medicaid Services has rolled out several programs to encourage states to provide integrated care. One program that I know is a program of all-inclusive care for the elderly. And many studies have proven that this model is not only cost effective, but extremely beneficial to people with mental illnesses as well. And because you guys are in such a unique setting in the academic field, I'm curious about your view on integrated care. How does it look like to you? How do you define that?
I'll let you go ahead with that.
Okay. Sure. So, integrated care is really, like you're saying, in the foreground of many health delivery systems right now. It's becoming very popular not only because of the attractiveness of that model, but because of how it helps with patient care. And so, I mean, we already see so many, amazing examples of by bringing behavioral health to the patients in the respective clinics, that it makes a tremendous difference in their overall health. It might help also perhaps to give a little bit of a description of the kind of place that we work and where we provide care. So the Social Action Community Health System, or the SAC Health System, is an interdisciplinary clinic. We have primary care medicine provided by family medicine, internal medicine, pediatrics, women's health, and we also have specialties that come over from the Loma Linda Health Medical Center throughout the week as well. So we like endocrinology, neurology, orthopedics is here on a regular full-time basis, and ophthalmology is here full-time. And so we also have a fully functioning behavioral health clinic as well as dental. And our behavioral health clinic consists of psychiatry residents who provide patient care a couple of half days a week. We have a nurse practitioner as well, and then we have psychotherapy, traditional psychotherapy provided by our psychology and social work providers. And then we have our community resource center, which is something we're also very proud of and excited about. Those kinds of services are very unique. We have master's level social workers and other individuals, bachelor's level social workers who provide community-based social services in a sense for our patients, getting them connected to community resources, helping with getting connected with vocational placement and various other imminent social service needs that our patients often have. And so we really endeavor to integrate all of this together right at the primary care level of when the patient comes in. So throughout the week, in addition to working in the specialty clinic, our behavioral health providers and our licensure track social workers from the CRC, as well as university psychology doctoral students from Loma Linda, throughout the week are placed within these respective clinics. And they are co-providers, in a sense, with the primary care provider.
Well, and I think it's also important to say that they extend the resources that we have. I mean, it would be wonderful to have a behavioral health clinician for every primary care provider, but the reality is that doesn't exist. And one of the other things I think is an important feature to keep in mind is there are lots of different studies and lots of different statistics, but one of the more important ones I think that we've heard in recent times is about 60 to 70% of people who come to the doctor probably have a mental health concern. And so meeting them where they're at is especially important because that may be the only opportunity, it may be the only chance that someone has to interact with them with that particular issue. They may have come to the doctor for a medication refill or a stitch removal or the examination of something. However, additionally, they've got some of these other concerns. And what we are finding is all it takes is asking someone. And then the doors open up and a dialogue begins, and service can be provided instantly in the context of that medical visit.
Yeah, I mean, it's a great point. We're not waiting necessarily for the patient to announce a need. We're there to screen for it. And it's also just part of the culture here with our providers that we're asking about it. We're making room for that mental health challenge that the patient may have and that they bring to the primary care visit. So yeah, it's really about bringing behavioral health, very proactively, to the patients. And so it becomes a great learning opportunity and a training opportunity as well for our pre-licensed, licensure track social work providers, the students from the University School of Behavioral Health, as well as people who have been practitioners in behavioral health for a while, but have never worked in the integrated care environment because it's a really different world. In specialty care, the psychotherapy visits are about 50 minutes, and it's really disconnected in a sense, oftentimes, from what's going on in the patient's medical care. To do the integrated care, we've adopted the model called the Behavioral Health Consultant, or BHC. This is a model that is popularized by individuals like the Cherokee Health System and others, and it again really takes the behavioral health provider and basically creates a model of care that's about 30 minutes long, that's very focused on functionality. It's very cognitive behavioral driven and behavior activation, motivational interviewing, and it's a shared goal that the physician has that with the patient, so that if the physician says, I have a patient here who's having a very hard time managing diabetes and they're also diagnosed with depression, then the behavioral health consultant now shares that goal and become a team member to work on the same goal with the patient, but bringing the behavioral health skills and the mental health skills to bear upon that patient's care.
Right.
And the communication is enhanced too, because everybody's working together in the same clinic using the same EMR, and it just enhances the patient's care and the experience of the provider too, kind of as the triple aim becoming the quadruple aim, and fourth component being provider satisfaction as well.
Yeah, that's great. So you guys are really using the behavioral health consultation to treat chronic illnesses, which is the true integrated care is all about. A lot of organizations, they claim that they're providing integrated care, but it's more like they're just putting behavioral health consultants with the primary care doctors in the same location, which is different than integrated care.
Right, and that's co-location, and that two people can sit anywhere and not have anything in common, and really not be working towards the goal of a common patient.
Yeah,
and so this really is, and one of the key features for integration as we conduct it here is the warm handoff. It's the provider, whether it's a nurse practitioner, physician's assistant, whomever it is actually warm handing off that patient to the next team member who's in a position to enhance the quality of care being delivered at that particular appointment. And that really, I think, is the crux of that shared appointment with the various team members. And I think it also conveys to the patient the importance of bringing in this additional team member to enhance whatever outcome, whatever impact the clinic is actually able to have for that particular day and that person.
Great. So can you educate us about the evolution of model of care in the States? We have pay for fee service. How do we get to now integrated care model?
Well, we are in a unique position as a federally qualified health center. And as a result, there are some things that we're able to do that may not be practical in a private practice, or they may not be practical in other types of organizations. And so one of the things that we are capable of doing, again, which is really to our benefit and to the patient's benefit, is we're actually able to bill for a medical visit and a behavioral health visit in the same day. And that's not the case everywhere else. And before we were an FQHC, it wasn't the case for us either. And what that does is it creates an opportunity to, in essence, be a one-stop shop and really put the patient at the center of what's going on, not the schedulability or not the provider ability, but really meeting the patient where they are in a given day. And the fact that we can be reimbursed for that is it is essential. I mean, we want to run a good business, and to run a good business, we have to be financially accountable and sound and those kinds of things. And so I think our position as an FQHC really enhances the capacity to do integrated care in a different way than it might for another type of organization. You have anything you want to add?
You know, I think that's I think that sums it up well, in the sense of, you know, we are blessed to be able to work in an environment where our billing structure does allow for a medical visit, a behavioral health visit, a dental visit, you know, all on the same day if the patient needs it. And that really is so crucial even for many people within the population that we serve. Transportation is very difficult for many of these patients. And so if they don't have to come back for the behavioral health visit or another kind of visit that's provided, that's tremendous for this patient, because it costs so much often for them to, you know, not just economically, but just in their daily life situation. The cost is often very difficult for them to come to the clinic. And also, this works the other way. So, for example, I was working with a patient on a return visit in the family medicine clinic, you know, not up here in behavioral health, but in family medicine. You know, I had a return patient who I had gotten connected with through integrated care. And our model allows for the patient to make a follow-up visit as well as a same-day visit. So I was working with the patient as a return follow-up visit, and she was out of a certain medication that she wasn't able to get filled in time. And since I'm seeing her right there in family medicine, I said, would you like to see if we can get you in on a same day to see your doctor here? And we were able to do that. After the behavioral health visit, that was the scheduled visit, we got the patient in for a same-day medical visit. And she got her need met without having to come back for another occasion. And it's so fulfilling to be able to do that. And it's so, the patients feel so grateful, you know, as well.
Yeah, because you're really going after the unmet needs.
Yes.
Correct.
Right.
And I think the other thing that is important is we are also, I think, to some extent, destigmatizing mental health care.
Yes.
So if we are bringing a friendly face into your comfortable, common medical visit, then there's less to be afraid of, and maybe more interest in taking an active role in working through some of the other issues that may be causing chronic diseases to deteriorate, versus maybe, you know, holding things at bay or even experiencing some improvements.
As professors, how are you guys advancing the model in the academic settings?
Well, there's a couple of ways, and I know Dr. Stinnett has got some thoughts about this as well, but actually bringing students here to experience it firsthand, and then setting an expectation that when they go out from this place as degreed professionals with licenses, then they may be able to impact or insert this kind of integrated care into whatever other entity they find themselves in. I think additionally, because we have such a high resident population through the various specialties here, we are also extending to them an expectation of what makes sense to have as part of their team, again, when they branch out after they've done their training and find themselves in all corners of the globe here.
That's a great foundation there, because we, you know, the difference between like academic teaching in the classroom, which both of us have done and have experience in, but then clinical teaching in the practice environment. So that really makes a big difference too, because of our relationship with the Loma Linda University and with the medical center, and it being you know, a graduate level institution for preparing healthcare providers. So, you know, we get psychology doctoral students, for example, coming down here throughout the week, and then working in the healthcare environment here, in the primary care environment. And then their supervisor can come with them, but then also when they do their own supervision, then it's direct clinical teaching about how to do integrated care. And my experiences as a faculty member in the family medicine residency program, and so I had the opportunity to teach family medicine physicians in training how to do behavioral health, and not just how to assess for it as within the scope of a primary care physician, but how to interface with behavioral health providers, how to communicate with behavioral health team members, how to know when it's the right time, let's say, to do a warm handoff to a behavioral health team member. And so they learn in this environment as resident physicians too, because most of our practice, the bulk of our clinical care is provided by resident physicians alongside attendings, and so they get to learn how do you communicate with behavioral health and other providers. We have sometimes we have clinical pharmacy on site, and we have the clinical nutrition dietitian providers here that we're ramping up in our clinic to become integrated care providers as well.
I think we're also setting the stage on what a resident, a physician, a nurse practitioner, what they can expect from us.
Yes.
And if we can set that stage in a training environment, then when they go out, it's an automatic ask. In order to conduct quality delivery of medical care, there are going to be certain team members that they expect, and or at least maybe this is the first time another organization is having this conversation with someone, because now we have proven the value of having that integrated connection and that team working around and wrapping around that patient. So I think ultimately our tentacles extend pretty far and wide because of the nature of the training that goes on here. It becomes an expected feature, or at least a hoped for or asked for feature when they move on to another organization, for instance.
I used to joke when I was residency faculty with family medicine, I used to joke, but not so jokingly, that my job was to spoil you so much during residency that you refused to do primary care without a behaviorist when you became an attending. And many of our graduates were going out to interview, and one of the first questions they would ask when they'd come back and tell us toward the end of their residency year when they'd interview for an attending position, they say, "Do you have behavioral health? Do you have behavioral health? Do you have integrated care?"
Yeah.
And the sites that weren't as strong weren't as enthusiastic about that.
But if they don't have behavioral health, like would they bring in that impact?
They bring in the energy for exactly. They bring in that energy to perhaps start some kind of behavioral health integration, and that's also equally as, I think, impactful.
Dr. Westerberg, were you trying to say something?
No, I was just saying it's really tackling one resident at a time, and one student at a time. And the others students that we bring on here are the MSW, or the Master Social Work students. We will be branching out to the marriage family therapy students. And so again, just making sure that everybody has a true appreciation for what the other is capable of doing and how to actually access and utilize those resources. And again, not everybody that is a student or a resident in our organization ends up working here. In fact, very few do. So we are looking at, again, the expanse of what our training and what our environment will actually do ultimately in the medical delivery system.
Right. Were there any challenges that you faced?
That's a really good question. I'll start it, and then Dr. Stinnett can probably follow up with it. I would say that it's simply the course of time. I would say that we have fewer challenges with residents today than we would have had with residents 5 years ago. And part of it is, again, just setting the stage for what can be expected in an environment like this, and what you can expect from your collegiate, your fellow healthcare providers. So I think that as we spend more time doing this and more people are exposed to it, the challenges are going to become less and less in some areas. Again, as I mentioned earlier, if we could have one behavioral health provider to every medical provider, that would be the ideal world. So I still see that having some potential challenges. And the other thing, too, is simply a matter of space. We can only have so many people congesting the chiefing room. There are only so many seats and only so many things that are going to be, we're going to be capable of actually carrying out. But I think as we have more and more residents going forward, we'll have fewer and fewer challenges convincing people that this is the right way to practice medicine.
Right.
Yeah, I would add to that the challenges are often in helping somebody to understand the model of care and how the different team members, like behavioral health, dietitian, clinical pharmacy, etc., can work in synergistically, almost as an organism unto itself, in the delivery of patient care. So understanding the model. One of the positives, though, in that regard for us is that once the resident or the provider, the attending provider, works alongside behavioral health and begins to utilize behavioral health more and more in direct patient care, they end up seeing how indispensable it is to have that provider there and the value that's created in the moment. And also the diagnostic and assessment data and information that the behavioral health provider can give back to the primary care provider, particularly because, as you know, many patients present to primary care with their main chief complaint as a mental health challenge, primarily depression, anxiety, post-traumatic stress, etc. And if the behavioral health person can go in there and do the quick assessment and then provide diagnostic clarification information back to the provider, then that informs treatment planning. That informs the kind of medication that is perhaps prescribed, as well as follow-up services or even integrated care follow-up visits. So in other words, so that helps with the buy-in right away and reduces the way that they might see that, oh, there's just the behavioral health provider or this person, the social worker, going to get in my way. No, they're not just there on the side.
Yeah.
They are there as a team member.
Yeah, a lot of the time that I see is that people with schizophrenia, they come into the clinic to see their primary care doctor. Their positive symptoms, like their hallucination or delusion, it overshadow their medical problems.
Absolutely.
But someone with the mental health training would go a step further and know how to really dig in that information.
That's a great point because the data really does show that oftentimes when a patient with schizophrenia or other psychotic disorder presents to primary care and they're undertreated medically for the psychiatric issue, because as we know, those patients have a difficult time staying adherent to treatment and taking their medication. Not only does the medication cause problems with, that like metabolic issues that can translate into diabetes and obesity and other things that compromise their heart health and their whole health physically, that ends up getting missed because the patient is actively psychotic and with positive symptoms in the room. So having the team there where it can be addressed from multiple approaches on a single visit can often be very, very helpful.
Right. So my next question is, this model really requires the infrastructure that allows it to happen. Do you think this model is limited to institution?
I think it's probably best started in institutions, like I said, like a federally qualified health center. And a lot of that has to do, I think, simply with the space available and some of the billing parameters that can take place. And so it's great to offer the best care possible, but it's just as great to be able to sustain that. And reimbursement is one of the things that allows us to sustain that. So I'm not suggesting that it isn't possible elsewhere. It hasn't been my experience at this point because we've been designated as an FQHC for about the last 4 years now. And so we've found that environment and that status to be very conducive. And we've got tremendous buy-in from leadership as far as conducting this type of thing. So it is possible in other realms. How exactly that would be conducted, I think it's a matter of interest, motivation, creativity, and then making sure that it's a reimbursable effort. It has to be.
I just want to echo what Dr. Westerberg said there too. On two levels. One is our leadership is profoundly supportive and promotes integrated care. The other piece is the creativity. One model as a package cannot be, I believe, superimposed on every single clinical environment and practice setting. The world that we live in here at SAC Health System, even as an FQHC, is going to be different than the one that the next FQHC down the road lives in because of our unique world, our unique relationship with the university, what we offer here as a clinic with multidisciplinary setting. And so you have to come in, I think, to from a programmatic perspective with an understanding of the different models out there and then not just simply selecting the one that you think will fit, but taking the model and then crafting it to your particular environment. So we have, like we've mentioned before, the different learners who come and how to weave them into a model of integrated care, how to take our licensure track social workers and weave them in, because then they also end up meeting their needs for licensure as well. And so then we invest in our, as a pipeline, into to our licensed staff. So I think that the key is creativity, but also flexibility, because you're going to, encounter obstacles along the way, and it requires flexibility to create solutions.
I think that the one thing that's key is people need to be feel safe enough and passionate enough to at least start the discussion.
Yes.
And looking at the quality and the characteristics of the organization or the practice or whatever the entity is that they're working in, starting out trying to get the buy-in, and then looking at a combination of things that might be helpful in carrying out and conducting. Part of the very first steps have to be creating a vision. What do you want to deliver?
Yes.
What in an idealistic setting would it look like? And can you start to get collaboration and develop partnerships with leadership? Now, if you're the sole proprietor of an individual practice, then you may have to network with others in the community to try and bring some of that additional support, at least to get it to be within an arm's reach or a phone call away.
How do you see the progression of the model in the next 5 years?
Well, I think we've been talking about mental health and behavioral health clinicians, and we have also been experimenting with our clinical pharmacists and our registered dietitians. But ultimately, I think that the team that's available to a patient is probably going to become quite a bit bigger on an as-needed basis. Not everybody needs to talk to the pharmacist. Not everybody needs to talk to the dietitian. But I think ultimately we start seeing additional key members identified and then accessible to the patient in the visit in the primary care, family medicine, internal medicine, whatever the visit happens to be. I don't know, how about you?
Yeah, I think that exactly the case. And as billing structures evolve with the models to support it, I think that even more makes for expansion of various other kinds of providers that can be available, at a primary care visit. And it's exactly right. Not every patient even is going to need behavioral health providers to participate in their care. And some patients who need it often decline too, for various reasons. And so, but exactly, I think that, again, the key is creativity and being a pioneer in integrated care. But again, our clinical setting here really helps us to be able to do that. Another thing I want to add as well is part of what I think is going to be the catalyst for growth of integrated care is the commitment to research. And what I mean by research is also just tracking patient progress, using tools that in place, even that exist already, such as screening tools, PHQ, GAD-7, various other substance abuse tools, etc., and have a commitment to using them on a regular basis to show treatment progress. And then that is then used to make the case for an expanded model, further investment, and for just the use of integrated care across different settings. If you can demonstrate that your program is creating patient wellness value and cost savings, even though we know that cost savings really at a macro level is often not seen for several years out. But if you can make a commitment to demonstrating that, it's an investment in your future.
I think the other thing that ends up being an investment is in the patient having an expectation that this is the way medical care is delivered.
Yes.
Ultimately we want a patient to go to a practice and say, oh, you don't have a behavioral health clinician? You don't have a team that can surround me? I may need to shop elsewhere. And actually putting the patient in the driver's seat as an advocate for the kinds of things that make that visit meaningful and have the biggest impact, I think, on whatever they're doing, their health in particular.
Great points. Any final thoughts?
I think one of the other things that I just want to mention is while somebody in a private practice or in a different system that doesn't necessarily have the reimbursable capacity, for instance, that an FQHC does, they may even start thinking about using people that we are referring to as community health workers or patient navigators. And so these are generally people with some very modest training, but who can make a huge impact in linking patients and linking people to community resources and doing a certain amount of outreach on behalf of the clinician as well as on behalf of the patient, and creating those partnerships. And that may be a very cursory first step for someone who's in a different system that perhaps doesn't necessarily enable them to have some of the flexibility that we have here.
Yeah, I think what I would like to add is that none of this can also happen without vision and the commitment from leadership to see what is possible with integrated care. And from Dr. Westerberg and our department here all the way up to our upper level administration, the vision for integrated care, without that, it doesn't happen. And so, vision and leadership vision has to be in place, and then quality of that vision that makes room for creativity and to look at what is possible, and to not get stuck in a box. Say, well, it's just behavioral health. It's not just behavioral health. I mean, that's a component, but to have the creativity to live in the possible, and then to say we can make this vision of what is possible a reality, and then you innovate. And so I think vision from the top down is essential.
And I think lastly, I would just say not being afraid to try. The first shot out of the gate may not be the one that works in that particular instance, and not taking the first failure as the ultimate failure, but recreating and renovating and making additions and doing some research as was suggested, and looking at other avenues that if you really have this as the ultimate vision, you may have some hiccups and some bumps along the way, but figuring out ways to overcome that. And creativity is one of those ways. In fact, for a lot of people, that creativity is probably what garnishes that endurance that allows them actually to get to a place where it does reflect what their initial vision held.
A lot of our meetings are like, well, what about this? We could do, well, what about bringing this in?
Right.
And that is so much fun. It's a very invigorating, milieu to work in, and a community to work in and live in. So, I think there's so much we could say about integrated care. Right. And having one additional thing is having the spirit of quality improvement constantly, in the foreground of your mind when you look at implementing a particular practice and or clinical function, and you say, okay, how'd that go? How do we tweak it? How can we improve it? How can we change it? How do we replace it? How do we expand it? So, you could get us going in ways which we enjoy anyway.
Yeah, thank you so much. You really inspire me, and I learned so much from this conversation.
For having us.
Actually, I have one last question. This is a question I learned from Dr. Manker. What are you both famous for?
Oh, that sounds like a Dr. Will Alexander question.
Yes.
Oh, that's a good question. I can tell you one of the things that I would like to be known for, whether I'm famous for it or not remains to be seen, is never saying no. Every idea is a good idea. Every idea is worth experimenting with and at least exploring. And ultimately, it may not, whatever comes to be in terms of the end result may not be exactly the way it started. But I'm very invested in my staff and in this process. And we're always looking, as Dr. Stinnett said, to do quality improvement. So I want to be famous for saying, absolutely, let's see what we can do.
I think similarly, I want to be famous for living in the possible, and for looking at what can we do that has not been done before, what can we innovate, how can we be creative, what is possible, having one foot in the actual and one foot in the possible, and I think that for me, I would love to be known for that.
Yeah. Great. To those who are watching, thank you as well, and come back for our next episode as we explore the question, what does it mean to deliver world-class mental health care?